record button. Travis, do you want to go?
I've got several cases. I can show a few and then
All right. Yeah,
save some for the end too.
Sounds good.
All right, do you guys see my screen?
Good.
All right. Some interesting stuff this week, and a few of them have nice, subtle radiographic findings. This is one I saw a couple of days ago. This is a portable radiograph, and the history is really important in this case. This guy, his history was bilateral rib pain, evaluate for rib fractures. And you can see he's got a chronic rib fracture here. And then I looked back and you know, it's, again, all my residents know, and Jeff has heard me say this too, that I think the lungs on like ICU portables are the least important thing, even secondary to the bones in cases like this. So you look back, he's had a PICC line in the past. This is an old rib fracture. And but what I noticed was, and especially with the history of bilateral rib pain, I always take one extra look at the spine, and you can see that his paravertebral, you know, the paravertebral stripes just look a little lumpy and bumpy, and it looks, you know, worse than it did before. And when you compare to even an older prior, that he looked pretty normal back in 2014. I've got to stop syncing these. And so then I mean, I don't usually pay this much attention to the bones, but I noticed that it looked like he had a compression fracture about somewhere here in the mid-thoracic spine, and maybe one here, that looked new from a month ago. And sure enough, digging back through an old spine MR, you can see that he has diffuse marrow replacement, but no fracture, no pathologic fracture here. So I called him up, and you know, with the history of bilateral rib pain, was worried about more of a central canal process. When I talked to the nurse practitioner, she said, yeah, there was no trauma. So he has a history of multiple myeloma, as you could have guessed, something like that from his appearance. And I thought this was all going to be hematoma around this vertebral body. I guess in retrospect, it's a little bit more diffuse and lumpy bumpy, but they did an MR later that day based on that CT, and sure enough, he's got two new compression fractures. I think this is the one that you're seeing right here, or pathologic fractures, new cord narrowing, which explains his symptoms at both levels. And on the axial views, it's not hematoma, it's all just presumably plasmacytoma myeloma that has progressed over the course of a month pretty rapidly. So this is, you know, it's a pretty subtle case, but on a radiograph, but something that, you know, with the history especially gave me pause and reason to look extra hard at the spine and the mediastinum. So, all right, let's see. This one is kind of interesting. The radiograph's not so subtle, especially when you look at the lateral view. This is a woman who I think is in her 50s. She's middle-aged. You can see there's an opacity overlying the right hilum, and I think you can argue that there's a hilum overlay sign here. I think on the PA view, what's more subtle though is that it's not just a right-sided abnormality, but you kind of lose the left heart border probably from some fat and scar in the lingula, but there's this just extra opacity kind of giving you a second heart border. And when you look on the lateral view, you can see this well-described thing, or well-defined thing, but then you have some filling in of what should be the retrocardiac clear space here. And so I'll show you her old CT first, because this is one that never really would have, I mean, this is not something you guess specifically the pathology. And I don't know what she originally presented with in 2013, but you can see this heterogeneously enhancing mass in the middle mediastinum that's either associated with or just abutting the posterior wall of the esophagus. It's pretty long segment mass, but due to insurance reasons and social issues, she was unable to get this taken care of at the time. And so now it comes back as this humongous mass with some areas of heterogeneous attenuation, probably some necrosis, and also some calcification. And we didn't have this outside study at the time. And one of my colleagues showed this to me and thought that, you know, it's pretty big, thought it was probably going to be malignant, like a leiomyosarcoma or maybe just a big leiomyoma of the esophagus. But this actually turned out to be a synovial cell sarcoma of the mediastinum. And it was actually separate from the distal esophagus. So this is, I could think she's 60 years old, so a little bit older than I said, but I think it, again, follows the rule that sometimes if you see a big and nasty looking mass anywhere in the chest, that weird sarcomas can pop up in multiple different locations. So I don't think anybody would have included that on the differential diagnosis, but it's kind of an interesting case nonetheless, and especially seeing the kind of slow evolution over 3 years. Now, this one, I think, is a really fascinating case, and credit to my colleague, Dave Nager, who was all over this case. This is a young woman who is in her 30s, and this was her radiograph this was actually after the CT, but it's the only radiograph we have. So her history was a month or 2 months and a couple of admissions for what was thought to be viral meningitis or encephalitis. She had mental status changes, memory loss, psychosis, all of these other symptoms. And on the second admission, they did the pan scan looking for suspected paraneoplastic syndrome. And so you can see again here that there's an abnormality overlying the left hilum. I think you can see the left hilum through it, so it looks like a mediastinal mass. You can see the descending thoracic aorta, so even on a portable, it's probably going to be anterior mediastinum. And so here's the CT, and sure enough, she has an anterior mediastinal mass, and it has areas of macroscopic fat in it, and a little bit of heterogeneity and calcification otherwise. So this looks like a mature teratoma of the anterior mediastinum. And my colleague, Dave, suggested that this could be the cause of the paraneoplastic syndrome, that usually you see that he was familiar with cases of ovarian teratomas causing paraneoplastic syndromes and encephalitis, and found a couple case reports of anterior mediastinal teratomas as well. So they treated her with steroids and IVIG. She got a little bit better, but they sent her home and then called her back about a week later when her paraneoplastic syndrome came back, and she was NMDA receptor positive and autoimmune encephalitis. And as I'll show you here, that they called her back to resect the mass, as the anti-NMDA is a known paraneoplastic syndrome associated with teratomas. Now this case series is misleading because they said associated with ovarian teratomas, but you'll see out of the 12 women, only 11 had ovarian teratomas, and 1 of them had a mature teratoma in the mediastinum. So this lady had her teratoma resected, and has had a few rounds of IVIG and has almost completely recovered her symptoms. So this is an interesting paraneoplastic syndrome that I wasn't aware of particularly. But have you guys seen this one before? I know we've shown some other paraneoplastic syndromes.
Oh, definitely not. Never heard of that.
So yeah, I thought this was pretty cool, and it goes to show that we do these paraneoplastic syndrome ones a lot, and they're seldom positive. But in this case, I would have never thought of a teratoma. But what's interesting in the pathology report, that there were a lot of neural elements included in this, and so that's what the antibodies were probably formed to. And it's a nice discussion by the pathologist here associated with this. So
very nice. Wow. That's
yeah. So add this to our list of different paraneoplastic syndromes. All right. Let me. I'm going to show one more, Jeff, and then I'll hand off and we can go around in a circle. Another radiograph, and this is credit to one of my other colleagues. I saw a follow-up on this yesterday. This radiograph is from 2013. This is an older man who is from Asia originally, came in with cough, and one of my other colleagues, Mike Hope, was all over this one. You can see that the obvious abnormality is this, you see a lot of nodularity, a little bit of volume loss, and probably some scar and bronchiectasis in the left upper lobe as well. But in the setting of cough certainly could be pneumonia, including tuberculosis, like an acute on chronic infection. And I think I probably would have stopped there, and you can see a little bit of it on the lateral as well. But he also picked up that there might be a second nodule here in the left upper lobe, or in the right upper lobe. And regardless of whether or not you see that or not, he went to CT. And I'll start with the right, just to show you this looks like a little adenocarcinoma, which is why we were following him up. But I think what's really interesting about this is that this did turn out to be tuberculosis. But, and Jeff and Howard, if you want to comment too, this is almost more of like tiny little granulomas like you see with a sarcoid galaxy sign, which I've never really seen nodules this small in the setting of TB. I thought but obviously it's asymmetric and unilateral, which would argue against sarcoid. So, and he had a positive PVD and responded to treatment for TB. So I thought this was kind of just a slightly different appearance of TB than what we're used to seeing. Do you guys agree?
Yeah, it is a bit unusual. I do see in a couple of places quite nice tree in bad opacities, or the bronchioles with bronchiolar branching. Yeah. So bronchioles are filled with stuff.
Yeah.
But it goes with the bronchogenic spread.
And
sure, yeah, it was just, yeah.
There's been also descriptions of like reversed halo signs that contain micronodules in the setting of TB and other granulomatous inflammation. And you kind of get the sense maybe that the distribution, I agree with Howard, some of this looks airway center, but some of it looks like more like maybe there was an organized pneumonia injury and the nodules remained from the granulomas, especially that consolidation up there.
Yeah, now this is the one from yesterday that I saw, and you can see that this is a couple years after his 4-drug treatment, and you can see that he's got the residual scar and upper lobe volume loss and bronchiectasis, but the rest of that's resolved, but this presumed adenocarcinoma is getting slightly larger. So just nice radiograph cases. So
yeah,
Jeff, I'll leave it there and pass it on.
Yeah, we'll come back around to you if there's time. All right, Seth, Howard, David.
I got cases.
All right.
So this is a case, I know Jeff had commented on this pattern before. I mean, the adenopathy is absolutely classic for sarcoid. What's interesting is this really pronounced peripheral directly subpleural consolidation, this kind of pseudoplaque pattern. And again, I came across this at our VA. I had not seen this pseudoplaque pattern before. I mean, I know it existed. And so this is just one of the million different presentations of sarcoid. The guy got treated. I mean, they biopsied it, the nose, to confirm it was sarcoid, and they treat him with steroids. And you can see just a few weeks after the steroid treatment that he had gotten much better. So I know there's someone showed Jeff, you had commented before differentiating sarcoid from silica based on pseudoplaques. Is that?
No, I mean, you see both. It's more the morphology of the nodules. The sarcoid nodules are like rattier looking, and the silica nodules tend to be rounder. But I did show one case of sarcoid that had more of the smoother, larger nodules.
This guy has absolutely no perilymphatic nodularity. It's just all this pseudoplaque.
His are because they don't look like they're made up of micronodules. They actually look like.
No, they're not. That's what I'm saying. They're just solid blocks of conglomerated consolidation, and I'm assuming it's sarcoid. Again, the nodes were biopsied and were proven to be sarcoid, and everything got better with steroids, including the nodal disease. And I was looking it up, and this pattern is reported. It's just something I had personally not seen before. So just, again, one of the million manifestation of sarcoid. I don't remember what this case is. Let me see. Oh, so this is one where kind of I myself went down the drain, kind of, but, no harm, no foul, except for the patient. So this is a guy who had this cavitary nodule, some surrounding consolidation, and you can see this necrotic-looking lymphadenopathy. He was a homeless gentleman. He had a history of tuberculosis, So there was concern for tuberculosis, which I think was fair. They recommended let's see here. They recommended that he be treated. He kind of disappeared for a while, even though I don't know how he disappeared, because supposedly they're not supposed to. And he came back in a few months later, and it's worse, and there's more consolidation, and the cavitary nodule's a little bigger, and the lymphadenopathy's a little bigger. And still heavily concerned, especially given the history of the TB. And then he kind of, they treated him for TB, but it didn't really work. And he came back a few months later, and he has this just absolutely massive area of consolidation, necrosis. You can't even see the underlying lesion. There's all this septal thickening. And so I was still very concerned about tuberculosis, especially given the fact that he has all of this, what appears to be, and I apologize, I shouldn't have just included the thin sections because it makes it very noisy, but very concerned given the necrotic lymphadenopathy. And I think the necrotic lymphadenopathy is better seen on the abdominal and pelvic imaging. So, we were wondering what was going on. We were still concerned for tuberculosis. So the amazing thing, well, not the amazing, unfortunate thing is, and you can see all these areas of these loculated collections and necrotic lymphadenopathy all throughout his abdomen and pelvis. This was biopsied in multiple sites, and it was all adenocarcinoma. So presumably that, and I still doubt it, but all the TB tests were negative, except that they actually, for the biopsy tissue. So presumably this cancer, it wasn't TB, it was cancer, just exploded and disseminated everywhere. Because they biopsied the nodes, the lung, and the retroperitoneal lymphadenopathy, and it was all adenocarcinoma. And again, this is, if people see the length of time, we're talking, this is 3 months that it goes from this cavitary nodule to this huge conglomeration of necrosis, lung necrosis, this necrotic lymphadenopathy, the superior abdominal stuff. I just had not seen an adeno progress that quickly. We all seen tumors progress quickly, but I was surprised by that one. And this is not that exciting. It's just a very pretty, if it will load up, very pretty case. It's just a nice example of SAM. So this is a person with hypertrophic cardiomyopathy, and there's a million different manifestations of hypertrophic cardiomyopathy. This one has the more outflow obstruction, so the anterior septal segment at the base. And it's just you can even see the flow acceleration. It's just a very nice case where during systole, the anterior leaflet of the mitral valve gets pulled into the left ventricular outflow tract due to the Venturi effect. And because the smaller the area, the faster velocity, actually the pressure is lower in here, so the anterior leaflet gets sucked in. And there's also regurgitation on another. You can see a little jet here, regurgitation. It was better seen on another sequence, but just a nice case of SAM. I won't waste anyone's time on the rest of the study, but it shows kind of the classic delayed enhancement pattern that you see in hypertrophic cardiomyopathy. And the last case is interesting for a couple reasons. So this is a guy who, this is 2011, and he's cruising along and is fine. And you can, what's really interesting is I just noticed the morphology of his left bronchus. Looks completely normal. So then he has a stroke at some point and starts to develop aspiration. And then if I can, let's see what happened here. And over time, he started developing this pronounced bronchiectasis and distortion, but interestingly, it was only in his left lower lobe. And I and there, although there is volume loss in the left lower lobe, look at the difference in the angulation of the left main stem bronchus. So he initially, that study I showed, had a pretty much normal appearance of left main stem bronchus. Now this thing has almost a severe posterior course, and he has findings of this aspiration, and this now continues for you know, multiple months, and he has these recurring aspiration events, and so somehow his, after a severe aspiration event, and this angulation of the posterior displacement is getting worse and worse, and there is some volume loss in left lower lobe, but it's really not bad. It's not that dramatic. I mean, both lower lobes there's volume loss, but he just has this unilateral what I'm assuming is unilateral persistent aspiration, because he is a known aspirator and he has multiple known aspiration events, but just this irregulation of bronchus, which wasn't on his initial study. So I don't know if he somehow, I don't know how this occurred. Usually you don't see a significant change in bronchial angulation or morphology like that. So I don't know if anyone else has seen a case like that where, you know, instead of coming off in its normal position, I mean, after a lobectomy or something, you can imagine that. But he hasn't had anything like that, just a stroke and then recurrent aspiration in that left lower lobe. So it's just kind of an interesting case.
So Seth, your concern is, why is there so much posterior dragging of that left bronchus? It seems out of proportion to the visible volume loss in the lower lobe.
I mean, there's some volume loss there, but it's this change in angulation which has, I'm assuming now, has predisposed him to severe aspiration in the left lower lobe, which is now what is occurring on a continual basis, because there's about 15 CTs on this guy since 2015 showing this, you know, findings of this aspiration event or potentially even some sort of chronic infection. But again, he's a known aspirator, and then they treat him and it gets better, and then 2 weeks later comes back and it's all plugged up again. And why his left main stem bronchus went from a normal orientation to this severe kind of coming back directly posteriorly, even though there's not dramatic volume loss. So have you seen that before?
Can you display this side by side with the earlier CT before there was?
Yeah.
Because I think the mediastinum has rotated more than you think. And so the lower lobe has lost some volume, but some of the retracking of that lower lobe bronchus is the mediastinal rotation, I think.
You're saying the mediastinal, what is the mediastinal rotation from?
From lower lobe volume loss, but some of the, no, let's see. Okay. So you can see that I think as you go farther down, the mediastinum, the anterior junction line has shifted, and notice that the azygosophageal recess is deeper now. So I think the mediastinum has slid off to the left, and I think the mediastinum has changed position. I think that's part of why this lower lobe bronchus has changed course.
But why would that? Do you know why that would happen?
Because there is lower lobe volume loss, but some of that is being compensated for by the mediastinal rotation and mediastinal displacement. So, in other words, the mediastinum has moved around, and that is contributing to the displacement of this left lower lobe bronchus. It's not just the lower lobe volume loss per se. So it would be helpful to have these two images side by side, and then to actually see how much displacement of fissure there is in the lung versus how much mediastinal displacement there is too. But it would take.
I mean, because here you can see it's at a somewhat. Let's try to find it. I mean, I don't know based on if there's rotation based on what structure you. So here's the takeoff of the right upper lobe bronchus here, and here's the takeoff of the right upper lobe bronchus here.
So notice the anterior junction line has shifted, and the depth of the azygosophageal recess has changed, so it's a deeper recess now. So in other words, the mediastinum has slid off to the left here, and it's
Yeah, no, I
has
see what you're saying.
the recess with it.
So do you think he had just one really bad left-sided aspiration event that then predisposed? Because, I mean, there are...
No, I think he has lower lobe volume loss, and it doesn't look as bad as it really is, because when the mediastinum moves in that direction, it keeps you from seeing the degree of lower lobe volume loss. So I'm not being very articulate about this.
No, I see what you're saying. You're saying that there actually is severe volume loss down there.
There's more severe volume loss than just looking at the lobe tells you.
Okay. But it's very, nonetheless, it's very impressive, and it's kind of a chicken or the egg thing. Like, how did he develop this severe lower lobe volume loss? Was it there was a bad aspiration event that plugged it up, and then it scarred down, and
it's probably ongoing.
Worse
it's probably ongoing aspiration, and bronchiectasis itself is a scarring process, and is a volume losing process.
But it's just interesting that the aspiration was so severe and unilateral that it led to, because usually I think of aspiration as normally a bilateral process. So he must have had a really severe aspiration event that was presumably unilateral to lead to this degree of volume loss.
He might have been lying on his left side at night.
Yeah, he may have been.
And directed it that way.
Yeah.
Well, we do see a fair amount of aspiration on our bone marrow transplant service, and it is often worse on the left than the right. I mean, we're taught to believe that aspiration should go down the straighter bronchus. That would take it into bronchus intermedius and right lower lobe. But sometimes it's predominantly left. So I think it may be on patient position or some other mechanical thing.
Yeah, now that this has truly become the dependent bronchus, and he keeps aspirating, it's just going to go in there for the rest of his existence, how long that may be. Okay. Anyways, thank you. That does make sense. And that's all I have.
Thank you, Seth. All right, David Howard.
I've got some cases. I can show a couple, and then we can go around.
All right.
All right. First, I'm going to show this case, which I know David will like a lot because David has taught us about this, and now that I'm looking for it more often, I see it when we have certain kinds of cases. So this goes back to a time when the patient has a history of breast cancer, and our surgeon, thoracic surgeon, was asked to biopsy some of these lymph nodes. I don't know if that was because another transbronchial biopsy was done and was negative. I'm not sure. But he performed a VATS procedure, and I'll show you the op note in a moment, to biopsy some of these para-aortic lymph nodes. So that was accomplished. Now let me bring up the preoperative radiograph, and I'm going to show you some radiographs after surgery, but I'll pick up a representative image from later on. So here we go. So the timing here is December versus July, and you can see there is a big difference in the location of that left hemidiaphragm. And to bring up the lateral from July, we can see that it is substantially elevated. The costophrenic sulcus on the left is quite a bit higher than the right. So that's a new finding from the preoperative radiograph, from preoperative imaging. So now I'll go back and put up the CT I just showed you with a follow-up CT. And it is this one. So scrolling down to the diaphragm down here, and look at that crus. So here's another example of phrenic nerve injury during the surgery, left hemidiaphragm paralysis with substantial atrophy of muscle, but including the crus of that diaphragm right there. So another really nice example of that phenomenon. So given what the surgery was and where the instruments were, undoubtedly a phrenic nerve injury. And the patient came back for a plication procedure the other day of that left hemidiaphragm. So David, I know you'll like this one.
Indeed. Thank you.
Great. So another one just like that. This one's definitely a case for fun because it's got a subtle finding, but I'm going to show it to you in part for fun. So here's a trauma case, and it's your everyday bad trauma. And as I do this, you can notice that there's trauma involving the shoulder, so fracture dislocation. There are also fractures involving adjacent upper left ribs. But I was looking at this and I thought I saw something, but I wasn't really sure. And then noticed the patient was scheduled for a CT and maybe headed to the CT already, so didn't really pursue it anymore because I knew we would be reading the CT really fast or really soon. So let me try and bring out what I was showing, and this again is just for fun. So if you look down here, there is, I hope you can see it, but there's kind of a lucency over here that projects over the spine. And just to indicate what I was looking at, it was this over here. So again, that's what I was looking at, and I wasn't really sure if it was real or not, but it was kind of intriguing and it caught my eye for a moment. So I'll leave that up there and bring up the CT, which I'm showing you this way in order for the correlation. So, looking for a pneumothorax in the usual places, going from posterior to anterior, right there. So here in the anterior hemithorax, there is a pleural air collection, and unless I'm making this up, this interface here corresponds with that interface there. So there is an anterior pneumothorax, so it's located, sorry, scrolling so fast, right there. And the X-ray beam tangent to here, of course, that interface will produce this thing over here. So a funny location, somewhat funny for anterior pneumothorax, and just producing this really subtle interface that one's lucky to pick up, but not a deep sulcus sign. So just a cute case. This is an interesting patient that we saw the other day. So a colleague of mine, a pulmonologist, came down because he was consulted. And the story in this patient goes like this. This patient apparently had some kind of abdominal pelvic symptoms. And we don't really have a lot of information about what her symptoms were, but suffice it to say that at some point in time, she got a CT, among other things, and you can see the lymph nodes that are adjacent to the aorta in the retroperitoneum. They were clearly concerned about a lymphoma, and a biopsy procedure was done, which I'll show you in a moment, but that revealed findings consistent with LAM, lymphangiomyomatosis. So he, of course, was interested in what the lungs show, and this is a situation in which the findings are really subtle, so I'm going to make it a bit big here. And of course, I'm looking for cysts, and starting down here, I really didn't see any. And then eventually got up to here, and sure enough, there are a couple, like here, small cystic spaces. They're really sparse, pretty few, pretty small there. In this context, I said, oh yeah, that's very much consistent with LAM. And we have that pathologic diagnosis. And even though there are very few cysts, the clinical picture for sure is such that one can confidently diagnose LAM like that. So that was kind of interesting. So here's the pathology report that shows the workup for LAM, and you can see it here, the things they do, and a description of a PCOMA, lymphangiomyoma, and so on. So the imaging findings in the chest really just confirm that. Let's see. This is just a nice correlation with RADPath. So this is in context of a lung cancer screening program. So let me bring up the most recent one before I show you the comparison. So the finding is right here in the left lower lobe here. And we have some previous, so I'll bring that up alongside on the right side. And I don't like that. Sorry, I'll go back to the lesion, which is really that here. Bring it up there. And this is the kind of thing that if you know where to look, you can see it before, but clearly not diagnosable before. So the interval of time here is 14 versus 16. Here it is before. And it's certainly a ground glass opacity. One can see some residual distorted air spaces within. This perhaps is a bronchus or bronchial-like structure that's pulled open a little bit. So in terms of pathology for ground glass, one would think of the in situ, the adenocarcinoma in situ, and then because it doesn't have a solid component, one would think of a lipidic growth of tumor. And sure enough, this is a adenocarcinoma, lipidic predominant, as you can see there. So great correlation between this description and what we see on the CT for this small lesion, lipidic predominant adenocarcinoma taken out. Okay, I'll stop there, Jeff.
All right, thank you. David, do you have any cases this week?
Not this week.
All right, I'll show a couple, and then we'll probably have time for a few more. Let's see. So let's start with this one, and I'll make it show the screen in a second here. Do this, and there we go. So this is a middle-aged woman who had a history of a spontaneous pneumothorax and has this chest CT here. And I'm withholding some of the history, but you can see this is a nice companion case to Howard's case. We see these very thin-walled cysts in the lower lobe. You'll notice this one's nice and round. I take it you can see the CT, correct?
Good.
Okay. This one here is more elongated, and you notice it's sort of running perpendicular to the pleura. And then we've got these very subtle cystic spaces along vessels. You see one here running along this vessel down here in the left lower lobe, and then this very odd-shaped one here along the spine. And you know, the other thing that's important with, so they're kind of everywhere. They're all very small. They're along the fissure. They're not nice and round like we see with Lamb. They're basal predominant. You might think about lymphoid interstitial pneumonia, another one here, but they're usually round or two. She should have some sort of connective tissue disease or immunodeficiency. Doesn't have that. But with any cystic disease, you can get a spontaneous pneumothorax. Now, what's interesting is her mother has renal cell cancer. She has an aunt who has a history of cystic lung disease. And so this was consistent, especially when you get these along the septopleural junction, with Birt-Hogg-Dubé syndrome. And I luckily found her dermatology note, which hopefully will open up. And let's make sure you can see that. Let's see, here we go. So you can see here, as turns out, she has a family history of Birt-Hogg-Dubé syndrome and had all the lesions on her chest, the papules, the fibrofolliculomas, the acrocordons, and the sort of the friction areas, skin folds, and some other lesions there as well. They did not send the lab test off for this, but I don't think they really need to in this case. But this is one of the more subtle cases I've seen, with very sort of polycystic disease and very, very small cysts. But even these small cysts were enough to give rise to a spontaneous pneumothorax. So pretty rare, but it's important. It is autosomal dominant, so they usually have a family history. And then the next day, we had another disease. This is a patient who has Sjogren's syndrome, who has a...
I can't see your screen anymore. Oh, there you go.
Yeah, I just said this. I don't know why my GoToMeeting always defaults like that, but I'll see if I can figure it out. So this patient had a declining DLCO. You can see there's some areas of decreased attenuation that look lobular, and I'll show the expiratory in a minute. But and there's a couple scattered nodules. Many look like intrapulmonary lymph nodes. But as we go down, you'll see there's some ground glass that's more than dependent, and then some thin-walled cysts in the periphery of the lung here. Very few polycystic disease, but lots of ground glass. Expiratory images, which is going to make it switch it. And there we go. Confirm that there is indeed some air trapping as well. So this is, I don't have tissue on this, but I don't think we really need it. This is a patient with LIP related to her Sjogren's syndrome, and with the cyst being just part of the manifestation, but this ground glass and some of these sort of ground glass nodules are probably areas of lymphoid aggregates and maybe some follicular bronchiolitis like that. And the ground glass is probably the reason her DLCO is down, not the cysts themselves, because it is pretty polycystic. But you'll notice these are all perivascular. You can see vessels running around the walls. They're a little bit more round than we saw with the bird hog tubé, and they don't have those weird orientations perpendicular to the pleura. And then the airways disease, I don't know if it's related or not. It probably is. There's probably some follicular bronchiolitis mixed in, causing some small airway stenosis.
Yeah, that's pretty likely, I think. Yeah, good.
And then just to keep along this theme here, I'm going to pull this up here. So let me just pull up the radiograph first, and I'm going to show you the radiograph. All right. So this is a patient who was sent to one of our pulmonologists for pulmonary hypertension, a diagnosis of COPD. And you can see the pulmonary arteries are large. The right ventricle looks a little bit big. The backwards lateral doesn't show them to be terribly huge. And you'll notice the parenchyma looks busy. It looks very almost reticular. You don't really see nice, well-defined vessels. This was the outside CT. This patient has some holes in the lung. So clearly there's some emphysema, but you'll notice, hold on, let me make sure you're actually seeing this. Are you seeing, yes, you are seeing the CT.
Yes.
You'll notice some of these have little walls, but per our previous conversation, you'll notice the caliber of the vessels is quite large, not the typical diminutive vessels you'd expect to see with diffuse emphysema, and especially as we get down to the lower lobes, there's quite generous pulmonary arteries. And as we get to the very bottom, you'll notice those black holes sort of almost disappear to almost nothing, to nothing at the very basis. So we're presuming this is actually an end-stage Langerhans cell histiocytosis with discrete cysts, and the pulmonary hypertension, I think, is an important component because it is recognized as a manifestation of the disease, and it's often much more severe than you would see with, you can see the RV is actually compressing the LV, the right atrium is enlarged, so there's right chamber enlargement. That the pulmonary hypertension with LCH is often can be quite severe, whereas, and it's associated with a poor prognosis, whereas with just bland emphysema, COPD type picture, you typically don't get pulmonary hypertension of this severity without some other cause. And I think, unfortunately, these weren't thin sections, but I think you can make out individual discrete cysts and the rather preserved architecture behind them.
Interesting.
Yeah. So
I think it's actually, I think it's pretty classic. It's a great look. Are they going to take her to transplant?
I think she's being evaluated for pulmonary hypertension at this point. I don't think she's sick enough quite yet. But
okay.
Yeah, we've seen a couple of these that they go to transplant for emphysema and the path is LCH.
Absolutely. Yeah, no, and this looks pretty good for that.
Yeah, it has that very dirty look to it, and in every case, the vasculature is preserved much more than you'd expect to see with the with emphysema.
Yep.
All right.
Yep.
Well, let's go back around again.
Was she a smoker?
Yeah, she was a smoker, big time. I don't know, Travis, if you had a few more, we have about 12 minutes or so.
Sure, I'll show 2 more.
Okay.
For now. So this one is another case along the pulmonary artery.
Yeah, Travis.
You see it now?
Good.
Okay. This is another pulmonary artery flow artifact case that happened to come in, as you see, last week. And I wasn't on for this case. That was on the weekend. And I'll show you, we'll go straight to the area of interest here. As you can see, the guy has some issues with slow transit of contrast. He's got pulmonary hypertension. I'll show you his lungs in a second. And you can see heterogeneous filling with very little contrast arriving in the left heart so far. And you can see in the left lower lobe that you have what I've noticed in a few cases, which is essentially like a contrast blood level where it's actually layering in the pulmonary artery. And if you notice here that you'll see one subsegmental branch that comes off and doesn't opacify. And then you see this, you can kind of hallucinate that similar contrast fluid level here. And if you look at his underlying lungs, he's also got UIP pattern. So he's got other reasons to have slow transit through his lungs as well. And they actually tried to repeat this PE study. These were both done, I guess this was done, they rebolused him a little later, and you can still see the exact same effect where you have a little bit of a contrast fluid level here, but this thing persisted, even if there may be a little wisp of contrast getting into that subsegmental artery. So I didn't see this until the weekend. So this was called a PE, and then I was working, and the pulmonologist came down and didn't even see which artery they were referring to. So we looked at that, and I still felt that this could be a flow artifact just because of the contrast fluid level here. And it happens that he also had an abdomen and pelvis CT done at the same time, but it was only done with 5mm reconstruction. So on Monday, I had them go back and reconstruct at 1mm intervals. And so this was done actually after the first injection, before the second PE injection. And now you can see that artery has filled in. It's this guy right here. So it's another confirmed slow flow smoke case, which this guy was actually started on anticoagulation because of that, even though it was just an isolated subsegmental artery. So another one where we actually have proof of it being slow flow. So
yeah,
I thought this was a cute one.
Yeah,
so I think the combination of slow flow from his heart failure and from his interstitial lung disease just resulting in increased vascular resistance and slow transit of contrast, particularly in those lower lobes too. So,
Travis, another interesting or important finding is that vessel, the alleged thrombosed vessel, was not dilated, which you would expect to see in a setting of acute PE.
Yeah, I totally agree. Yeah, I'm a skeptic on these. I dug up a recent article from a couple years ago from the Netherlands where they compared artifacts on 64 versus 4 slice scanners, and you guys may have come across this in the past too, but they found that they had a similar number of inconclusive studies. It was just on the newer scanners they were more likely to have flow artifacts. Unfortunately, they didn't really differentiate whether it was all transient interruption of contrast or mixing like this, or just differences in bolus timing. But obviously we've collected a lot more of these now.
Yep.
All right, and then this is I'll just poll the audience here and see what you guys think. This lady has a lung cancer, and the question is, where is it? So I benefited from seeing this one retrospectively. So
hold on. Near the left first costochondral junction, projecting over a posterior rib.
Right hilum area.
Right hilum, maybe, I don't know.
Right hilum based on the PA or the lateral view?
The PA. Can you flip the lateral around? My brain will.
Yeah, I know. Sorry. I think the University of Michigan's the only one that actually views them this way. But yeah, there we go.
Yeah, the lateral's
Okay, so just focusing on the hilum a bit more. I don't know. Maybe superior and posterior to the left upper lobe bronchus, there may be more opacity than is just a left pulmonary artery, maybe.
I think this is another example of where you're missing a normal structure in the left hilum.
In the right hilum is out, I think, Travis.
Say that again, David?
The PWBI, posterior wall bronchus intermedius. I think the line that we're seeing there is the scapula.
Yeah.
No, that's it. It's the thick. It's where that's it.
Yeah.
Or that thickness there, which is many millimeters thick.
Yeah, the posterior wall of the bronchus intermedius should be right in here, because this is the left main stem upper lobe continuum under the left PA. Yeah. So it's,
and just above it, there's a white rod-shaped thing, which is too much opacity. That corresponds with the CT.
It's probably this thing right here.
Yes.
So,
yes, all of that.
And, what's amazing too is just how big.
Yep.
And notice this is 3 weeks after that radiograph. And so, yeah, Jeff, I agree. When I looked at it at first, I thought the right hilum was a little funky, but I would have never guessed there was something this big. And then, of course, in the lateral view, it's more just the absence of a normal structure that's so hard to see.
Well, it's also that underneath the left bronchus, there's ill-defined tissue. There's too much whiteness down there, so there's trying to turn into a donut, and it didn't quite make it.
Yeah, but I just thought this was another fascinating one that just, if we do a little thick slab, you can see there's the posterior wall of the bronchus intermedius, and if I can thicken it up. Yeah, and as David said too, there's a little bit, maybe a little too thick. Yeah, just a little extra fullness below the hilo as well. But yeah, super subtle case.
Yeah.
So,
These are scary.
yeah, this is a squamous cell. So, all right, Jeff, I'll hand off there.
All right, Howard, you got one more? I can show another one. It's up to you.
Okay, I can show one. Let's see, I've got some. I can, if you like, I can show one more. Say, pick out a nice one if I can. Okay, this one's nice. This is a young person that came in with chest discomfort. I don't know the details. I'll bring up the case in a moment. But here is the frontal projection of the chest. There is a mogul and an opacity there, which shouldn't be there. One can see that it is relatively anterior, so I'll bring that up again. So mediastinal mass, relatively anterior in the chest. Here is the corresponding CT. We go right down there, and we see this opacity exactly where we expect to see it based on the radiographs. It has got some low attenuation within here, but otherwise it's contiguous with the pericardium, and it's located in fat. So a mediastinal mass, relatively anterior, young person, and there's a differential for that, of course. Let me try to bring out the low attenuation component. So there's the T's. I don't like acronyms, but it's the lymphoma, thymoma, the teratoma, and low attenuation there. So this is a teratoma. What's interesting about it is that on path, he had that, but there was evidence of marked inflammation, suggesting to the pathologist that there had been an episode of a prior rupture of it with surrounding inflammation and granulation tissue reaction, as you can see there. So a mature teratoma with pathologic findings of prior rupture. And certainly the CT findings are very consistent with that, and that was taken out. So a nice example of that. Okay, Jeff, I'll stop there. You can show your case to finish up with if you like.
So one last case here. It's a pretty straightforward one. Let's see. Show the radiograph first, and let's see, radiograph. If it'll, there we go. All right, so this is a patient who had a kidney transplant, and you can see the patient with short breath, fever, cough. They're diffuse tiny little nodules throughout, so a miliary pattern. So TB, and of course in our neck of the woods, endemic fungal infection would be highest on the list. And here's the CT scan, which I'll now show you. And just a beautiful example of randomly disseminated micronodules, so a miliary pattern. And the differential doesn't really change much, but it confirms the distribution of the nodules. So this is histoplasmosis. We don't know where the patient got it from, but it's everywhere around here. And so even though miliary TB is more common where we live, miliary histo tends to be the more common one we see. But this was, they got this one with culture, and interesting, the blastomycosis antigen was also positive, but apparently according to our ID folks, this is the urinary antigen. There's a lot of cross-reactivity with these, so we can't rely solely on these. So a miliary histo.
So he's not a caver or working in the attic where you're inhaling a number of organisms?
No, we've seen that, people, on mild immune suppression for like inflammatory bowel disease, going caving and stuff. But or but it's in the soil around here. Birds, bats, so it's that time of year too where there's lots of birds out, and so it can get aerosolized. Construction, bridges, telephone poles, urban chickens, you name it. It's pretty much everywhere here. It's not. We're not at sort of the hot spot like along the Mississippi and the Ohio rivers, but it's enough that we still see it. Miliary histo.
What's an urban chicken?
Oh, people have chickens, in their backyard for eggs. My chair has chickens in his yard, so he has urban chickens.
Fascinating.
Yes.
Are they different? Or they have a higher propensity to develop histo? Those urban chickens. They get them from the pigeons.
They get them from the bats. Yeah, they're carriers of histo because their high body temperatures. It's able to exist in their body, and then it's passed out in their excrement, and then it becomes a spore, and then it gets you clean out the coop, or but it's been reported in like telephone line workers who go up and disturb a nest. You just have to get enough of it. I mean, most people are seropositive. We see calcified nodules on almost every chest CT we read here from old histo, but if you get enough of it, you can actually get pretty bad histo, but it's pretty uncommon to see.
It's in pigeons in cities too. So
yeah,
in most birds.
Yeah, and it's actually been reported worldwide. It's much more common in North America, but there's cases of it elsewhere in the world too, and except in like parts of Southeast Asia and Australia, where it's all from people coming back from North America with it. That's where they mostly see it. Okay, well, great cases, everyone, and we'll meet again next week.
All right, take care.
Bye-bye.
Thanks. Bye-bye.